Good morning again.
Good morning.
I'm Ian Barrett from the Department of Human Resources. Thank you very much for coming to help us celebrate Pride at UTMB. So at UTMB, we are very proud of our diversity. We strive to create an inclusive place for our students, for the people who work here, and all of the people who come to us for service. And so we're really excited about celebrating Pride and welcoming Dr. Michael Hoff, who's here from the VA, Baylor School of Medicine, and other places to talk to us about LGBT healthcare. So with that, I'll close my comments and turn it over to Dr. Hoff. Thank you.
Thank you. Thank you. Thank you for the invitation to come talk to you. This is my first time at the UTMB campus, and it's a pleasure to be here. I love talking about LGBT stuff. I'm one of the two directors of the LGBT health program for VA in central office in Washington, D.C. We've had an LGBT health program since 2012, so we're pretty new. And we're small. I split the job. We have one FTE. I split the job with a fellow director, Dr. Jillian Shippard, who is a psychologist in Boston. I'm located in Houston. And we have a couple of staff on contract who work with us. And I'm going to talk some about what we've been doing in the LGBT health program. I hope you'll be impressed with the variety and also the quantity of the work that we've been doing. Because this is a half-time role, I have another job. I'm also the co-director of the VA South Central Mental Illness Research, Education, and Clinical Center, or MIREC. This is one of 10 specially funded mental health centers of excellence that focus on a particular aspect of mental health care in VA to conduct research and to develop new clinical and education innovations to promote better access to care for veterans and better quality of care. Our special emphasis is on rural veterans and those who experience barriers to care, and we can include LGBT veterans in that group. I'm also a professor in the Department of Psychiatry at Baylor College of Medicine, and I teach a course on LGBT health. So I'm going to talk to you about the state of LGBT healthcare and use the VA as an example, because I think in a lot of ways we're on the cutting edge, or we're leading other healthcare organizations in this area. And although that is probably true, there is still a lot more that needs to be done. I hope that other agencies can use our example and learn from us and take things even further. So let's go ahead and get started. I have no financial disclosures, but I do want to thank my colleague, Dr. Jillian Shippard, who helped prepare some of the slides that I borrowed from previous presentations I'm going to show you today. I want to step back for a moment and define some terms to make sure we're all on the same page and give you a little bit of background about the VA so you have a better understanding of what I'll be talking about. So of course, I'll be talking about LGBT people. This refers to lesbian, gay, bisexual, and transgender folks. You've probably seen other letters following LGBT, like Q for queer, or questioning, or I for intersex, or A for asexual. I've seen a half dozen or more terms or letters following LGBT. And we decided we couldn't keep up with all of them, and we'd leave a letter out, and that would be a problem. And even if we could keep up with all of them, it would be a really awkward acronym to use. That's 12 letters long. So we decided to keep it very simple and use LGBT inclusively. So this is a big, broad acronym that encompasses a diverse group of sexual and gender minorities. And it makes it easy to talk about their common experiences of stigma and discrimination, especially around healthcare, which we'll be talking about. But often the differences get lost in using that acronym, and people forget how they're different. So I want to point out just a couple of key differences before we go any further. Of course, the lesbian, gay, and bisexual folks, the LGB part of the acronym, are connected by sexual orientation or non-heterosexuality. That's part of what defines them. Transgender folks in this acronym, the T part, they have a sexuality, they have a sexual orientation, but they may be as likely or more likely to identify as heterosexual, as a non-heterosexual sexuality. What defines the transgender group is a gender identity that may be incongruent with their sex assigned at birth and a broader gender expression. A subgroup of these folks may meet criteria for a DSM-5 diagnosis of gender dysphoria, but not all of them will. So I've mentioned sexual orientation. This is also a global term that refers to the sex or sexes that one is attracted to, or even the absence of sexual attraction. The difficulty with this term is that there are multiple dimensions of sexual orientation. And people don't often consider that when they're talking about sexual orientation. They may use the word as if it's only referring to sexual attraction, which it does. But it also encompasses sexual arousal and fantasies and sexual behavior and the words that people use to define their sexuality. And the problem is that those aren't always congruent. They don't always line up. So it's important when we're asking about sexual orientation to be clear about what aspect we're trying to get at, what we're asking about. Is this really about sexual behavior because we're interested in sexual health risk? Is it about sexual identity because we're interested in how people describe themselves and we want to be respectful of that? And because a lot of health disparities are keyed around identities? Or is it about something else? So we just need to be clear about what aspect of sexual orientation we're referring to. I also want to define and talk about sex, gender, and gender identity. I know these are very basic terms, but really smart people get these confused all the time. And so I want to go over them. There are multiple definitions of sex, but the one that we're most interested in here is physical anatomy, because this is important to sex assigned at birth. When a baby is born, usually what happens is the physician looks at the infant's genitals and says, this is a boy or this is a girl, and marks the box on the birth certificate. And until just recently, there are only 2 boxes in all birth certificates across the US. Does anybody know what state has a 3rd option? And you can't answer. Does anybody know? California? Nope, not California. Nope. It's New York. New York State has, just in the last couple of months, been offering a 3rd option called intersex. And that may pave the way for other states to do this. I just heard on NPR today about states considering adding gender markers and more options on gender markers for state ID. Apparently, of course, all states have their different rules and regulations and what they put on a state license. Now, gender refers to the behavioral, psychological, cultural traits that we associate with being a boy or a man or a girl or a woman. The adoption of those traits, the expression of those traits, the internalization of those traits is considered gender identity, how we think about ourselves and express our internal sense of gender. If you have a gender identity that's consistent with your sex assigned at birth, you are a cisgender person, in contrast to a transgender person whose gender identity is not congruent with their sex assigned at birth. All right. In the last month, the VA has begun a kind of a 2-part identification of sex and gender identity. We've always had a sex field in our record system, and that's done double duty as both sex and gender, which is not very efficient. It doesn't work very well if your gender identity is different from your sex assigned at birth. There's only one field. And it's important to distinguish those two. So in the last month, we've begun making changes in the medical record, actually across all the record systems, not just the medical record systems. And now the sex field has been renamed birth sex. And if a new veteran comes to enroll in the VA for care, they'll be asked what sex was listed on your original birth certificate. And they'll also be asked the second question. Do you think of yourself as, and there are these options that'll be on a drop-down menu. I didn't come up with these options. These are not the ones I would have chosen. This has been in the works for at least 5 years, and it's not possible to change these things once that train starts rolling. It's better to let it get to the station and then make some changes. So the options are male, female, a trans man, a trans woman, other if the veteran has another word that they use to describe themselves. Unfortunately, it's not an open text field, and so we won't capture that information. It'll just be a check box for other. Or the individual may choose not to answer. It's perfectly fine not to answer the question at this time. So new enrollees will be asked this question when they establish their eligibility and they create the new record for this individual in our system. Current enrollees in the VA system will be asked this question when they come to their next clinic appointment. So it will be clinic clerks who ask this question, because this is a demographic field. It goes across the entire record system, not just the health records. And this new field has been created in the last month, and clerks are beginning to ask this question, and we can actually check to see if the field is being populated across the system, and it is showing up, which is pretty cool. We developed some training to roll out to help the clerks do a better job in asking the question and responding to veterans who may have questions or may be upset or angry at being asked a question like this. And we've actually tested the effectiveness of that training, and the clerks have found it to be very useful. But we have a long way to go. We've got about 9 million veterans enrolled in our system, and right now only a few hundred have this field populated. So it'll take a couple of years for there to be enough data in the system to really look at in a meaningful way, but we've started. So let me back up and tell you a little bit more about the VA. If you don't know, the Department of Veterans Affairs is really made up of 3 branches, and the Veterans Health Administration is by far the largest. That's the healthcare branch. That's the one that I work for. That encompasses all the hospitals, the outpatient clinics. There are over 300,000 employees in VHA. The second biggest is VBA, the Veterans Benefits Administration, and this is the branch that coordinates compensation and pension evaluations and payments to veterans if they have a combat-related illness or injury, and it coordinates education benefits. And then the last one, the National Cemetery Administration, which is the last stop for veterans who are enrolled in VA. There are about 22 million veterans nationwide, but most don't come to the VA. Only about 9 million are enrolled in, only 9 million are enrolled in VA. That is a huge number, and we see a huge number of patients at our facilities. Many of them come just to get their medications because it's cheaper to do it through the VA. Some get some of their care at VA and other care outside of VA because they have private insurance, and that's fine if they want to do that. We're also unique in that we are associated with the government and with the military. And the military has a long and unpleasant history in dealing with gay, lesbian, bisexual, and transgender people. I hope that's not a surprise. Before Don't Ask, Don't Tell was implemented in, I think, 1992, the Department of Defense had a long-standing ban on people who engaged in same-sex behavior. In fact, their regulation stated that homosexuality is incompatible with military service. Very similar to their statement about, I believe it's called transsexualism is incompatible with military service. So for a long history within the military, they have banned or excluded and would discharge people if they identified themselves as gay, lesbian, bisexual, or transgender. Don't Ask, Don't Tell was intended to be a better policy. It was, or at least that's how it was presented. Some people never believed it was going to be better, but the intent was, or so we were told, was that gay, lesbian, bisexual people would not be asked their sexual orientation anymore. So they could serve in silence. As long as they didn't say they were gay, lesbian, or bisexual, everything was cool. Didn't work out that way because lots of military folks asked, investigated, and there were about 14,000 lesbian, gay, bisexual service members who were discharged under Don't Ask, Don't Tell. Don't Ask, Don't Tell was repealed in 2011. That didn't change the military's policy on transgender service personnel. They were still viewed as incompatible with military service until just a year ago, when the military changed their policy on transgender service members and opened up all branches of service to transgender personnel. That also meant that they would start providing health care to transgender service members, something they hadn't been doing before. So this was a big, big, big deal. Mentioned that already. So the VA has to deal with that baggage that veterans experienced while in the service. Discriminatory practices, stigma around being LGBT, and unfortunately many LGBT veterans who come to the VA come expecting to be discriminated against. I'm going to talk a little bit more about this research a little later in the presentation, but that is a hurdle that we have to overcome. They come expecting to be discriminated against. In 2011, same time Don't Ask, Don't Tell was being repealed, the VA issued its first national healthcare policy on transgender care. This has been in the works for a while. There were VA facilities across the system that had different interpretations about VA policy on transgender personnel. There wasn't an explicit national policy. And so different hospitals were interpreting things in different ways. It was creating a patchwork of differences in healthcare. That was not okay. And so a national policy was issued in 2011. And this established that VA would provide for transgender veterans gender counseling, hormone therapy, pre-surgical evaluations, and medically necessary surgeries post-surgical sex reassignment. And this actually happens quite a lot. If veterans go outside of the country to get gender transitioning surgeries, come back to the US, they may be complications. They can't go back to Thailand to see their surgeon. They'll come to the emergency department in the VA and get care there. The VA does not, by regulation, provide gender transitioning surgeries. We're prohibited from doing that, or cosmetic procedures related to gender transitioning. And I can talk more about that a little bit later. We don't have a directive on healthcare for veterans who identify as lesbian, gay, or bisexual just yet. We've written it, it's in concurrence, it's working its way to get approval through all the program offices and central office. We hope it'll be out this summer. It's very close. And what it will do is ask providers to do two things: to assess, to ask their patients about their sexual orientation identity, and to do a brief history of sexual health. And record this in the medical record. Something we should be doing anyway, and we don't do. So I'm very happy that we'll be able to get this out there and provide this additional service and benefit, because I think it's a benefit to everyone, to all of our patients very soon. All right. How many LGBT people are there? A group called the Williams Institute looked across several national surveys and estimated that on average there are about 3.5% of Americans identify within this umbrella term of LGBT. And that would be about 8 to 9 million Americans. Not a small group. We don't know exactly how many LGBT veterans there are because the military doesn't ask this question. They don't record this information, thank you, in any way that we can compile. And the VA hasn't been recording this information until just recently with gender identity, but that's not enough data to tell us anything yet. The same group, the Williams Institute, looking across survey data, has estimated that there are at least a million LGB veterans, or almost 3% of the veteran population. So you can see that's within the range of the national prevalence. What I find really fascinating is that within that 3% that identify as lesbian, gay, or bisexual, the majority are women. Majority are lesbian, bisexual identified women, even though women make up a small percentage of the veteran population. Only about 15% of the veteran population are women. Why is that? I don't know for sure. More work needs to be done. This is an emerging field, and I'm very excited to anticipate what we're going to be learning soon about all of this. The same think tank group, the Williams Institute, has also estimated there are at least 134,000 transgender veterans. At least 134,000 veterans. That's a little less than 1%. Now, in this case, we can look at VA data for proxies, using proxies of transgender identity. We can look at diagnostic codes for those veterans who receive transgender-related services. And a group of investigators did that, looking between 1996 and 2013, and identified over 5,000 transgender veterans, unique transgender veterans in our system. We've got a paper that is working its way through review right now, where we use the same diagnostic codes and found over 7,600 transgender veterans in our record system. So I don't know that means that there are more transgender veterans coming to the VA. I think it certainly means that we're recognizing and diagnosing and treating more transgender veterans in the VA. Another group of researchers looked at one diagnostic code, gender identity disorder, and found a prevalence rate of veterans in VA that was 5 times higher than you would expect to see in the general population. 5 times higher, that's remarkable. I'm not sure how to explain that. Again, more work needs to be done to tell us why transgender veterans may be more likely to, transgender people may be more likely to join the service. There's some speculation about that, but more work needs to be done. I certainly think it's true that the general population prevalence data is too low because it primarily looks at clinic data. So I hope everyone here appreciates that LGBT people as a group, experience some mental and physical health conditions at higher rates than non-LGBT people. And they are more likely to experience barriers to accessing health care compared to non-LGBT people. And that's true of other minority groups within the majority culture. Now, very, very few of those health disparities are related to sexual behavior. They're related to other things, as you'll see in a moment. I think one of the best explanations for these health disparities is minority stress theory. How many of you have heard of minority stress theory? Anybody? A few hands? Okay. The idea here is that within a majority culture, a minority group, in this case LGBT people, experience a great deal of stress and pressure from culture, from society, and that stress, that pressure is manifest as anxiety or depression, even suicidal ideation. It can lead to maladaptive coping, like drinking too much, eating too much, doing drugs, not exercising, not seeking health care when you need it. That can contribute to the progression of chronic disease that doesn't get treated. It can also contribute to societal level barriers to accessing health care, like lower paying jobs for LGBT people, like difficulty accessing health insurance to pay for health care, and not teaching healthcare providers how to care for LGBT people. Most medical schools spend very, very little time talking about LGBT health issues. And other health disciplines are really no better. It's improving a little bit, but we have a long ways to go. I've been out of school for 30 years. I can tell you that my graduate program, I'm a clinical psychologist by training, gave me zero training in LGBT health issues. LGBT people were something that was exotic. Now, we might encounter these folks somewhere along the line, and if we do, we should just treat their depression or anxiety like we would anybody else and not pay too much attention to this other stuff going on, because we don't really know what that's all about. Fortunately, we've progressed a lot since then, but our professional education programs need to catch up. And there is interest. Actually, I'm gratified because it's young people, it's young students who are coming in asking their schools to include this information in the curriculum. I know that's true personally at Baylor because that's how the LGBT health course started. Is students said, we want this information in the curriculum, can you help us get it there? So the important point is, the take-home point is that sexual orientation and gender identity are both social determinants of health. These are both important to the health attitudes, the behaviors that people engage in, and their health outcomes. So we should be asking about them and tracking them. We should be doing appropriate follow-up based on what people tell us is their sexual orientation or gender identity. Just like we need to track sex assigned at birth, age, ethnicity, where you live, locality, because those are all important social determinants of health. They play a big role in health attitudes, health behaviors, and outcomes. All right, I'm going to talk about the intersection of LGBT identity and veterans a bit more. So, I made the case that LGBT people experience, as a group, higher rates of certain mental and physical health conditions compared to non-LGBT people. You probably know that veterans are at higher risk of some mental and physical health conditions compared to non-veterans. So it makes sense that LGBT veterans would experience higher rates of mental and physical health conditions compared to non-LGBT veterans. And indeed, that's what we find. There is a small but a growing literature on this, finding exactly this outcome, that as a group, LGBT veterans have higher rates of trauma, including military sexual trauma. And that's especially true for lesbian and bisexual women and transgender service personnel. Military sexual trauma. So they've been sexually assaulted in the military by other service members. Higher rates of PTSD, higher rates of substance abuse, including smoking, and in general, poorer mental and physical health outcomes, including higher rates of suicidal ideation. And I want to spend a little bit more time talking about suicide risk because this is the number one priority in healthcare in the VA as addressing suicide risk and preventing suicide. So from a population-based survey in California, they found that LGB veterans had more than twice the rate of lifetime suicidal ideation compared to heterosexual veterans, more than twice the rate. And an interesting study that was done at nearly 100 universities looking at veterans enrolled in colleges or military students enrolled in those colleges. And in this case, the study categorized people by sexual behavior, not by identity. But those veterans and military students who had engaged in same-sex behavior had increased rates of suicidal ideation and attempts compared to their heterosexual peers. And women, veterans and military students who had engaged in same-sex behavior, had the highest risk for suicide attempts compared to any of the other groups. Highest risk. So even engaging in same-sex behavior is a social determinant of health. We should be asking all of our patients about veteran status, if you're not at a VA, sexual orientation identity, and gender identity. Let's look at transgender veterans and their suicide risk for a moment. An online convenient sample of over 200 transgender veterans, 2/3 reported a history of suicide attempts or plans, 2/3. And over half had reported past year suicidal ideation. And some data from the VA, again, using one diagnostic code to track transgender veterans in the VA, they found that those veterans with this diagnostic code had a 20 times greater risk of engaging in suicidal behavior, 20 times greater risk than other veterans enrolled in VA. And we know that veterans are at higher risk of committing suicide than non-veterans. So this is alarming. And from the National Death Index, looking at veterans with, I think, 4 different diagnostic codes related to transgender services, they found that transgender veterans who had died of suicide died at a much younger age, almost 10 years younger than other veterans who committed suicide. And the suicide rate of transgender veterans was more than double. It's a big concern. We should be asking our veterans about sexual orientation identity and gender identity, and healthcare agencies outside of the VA should be asking the same thing, including veteran status. Good news for the VA is that we see some evidence of higher rates of VA use among LGBT veterans. They're more likely to come to the VA for care compared to non-LGBT veterans. Why might that be? It's not clear, but it could be just a function of the VA being a catchment facility. This is the place to go if you don't have private health care insurance. Maybe because of a low-paying job, maybe because you have difficulty accessing health insurance through your job, or you've lost your job, or because you have chronic health conditions and insurance companies don't want to cover that, or if you have service-connected health conditions, illness or injury related to your military service, are all reasons to come to the VA. I didn't report this, but in a study that someone else did looking at service-connected disabilities, transgender veterans, those we could identify with our diagnostic codes, had higher rates of service-connected disabilities than non-transgender veterans. So they're more likely to have experienced an illness or injury that's military-related, probably combat-related. Another survey from 2008 also found elevated use of VA for transgender veterans. All right, I mentioned earlier that LGBT veterans come to the VA expecting to be discriminated against. We did a study a couple of years ago with about 58 LGBT veterans at 2 hospitals. And one of the things that we asked them was to rate potential barriers that would keep LGBT veterans from coming to the VA. And the #1 rated barrier was this one: hurtful, rejecting experiences in the military. Well, why would that make a difference? This is in the military. We're in the VA, completely different organizations. Why would this make a difference? Any guesses? Culture? Mm-hmm. Veterans presume we're all the same organization. They don't make the distinction between the Department of Defense and the Department of Veterans Affairs, or understand that we have very different policies. It feels the same to them, and frankly, the VA has a very prominent military culture. You know, it serves military veterans. It grew out of the need to serve military veterans. A lot of folks from the military helped found the VA. And so its structure is very militarized. And so it can feel that way. And we have always known that other veterans, non-LGBT veterans, associated the VA with the military. This is a quote from a lesbian female in one of our focus groups that I think nicely illustrates this finding. She said, "I look at the VA as an extension of my experience on active duty. At a moment's notice, somebody could come in and just say, 'You're a lesbian, and I'm going to snatch your retirement income from you right now and all of your benefits,' and it would be gone just like that." That's a perception. It's never happened. The VA has never had a policy that prohibited care to LGB or T veterans. If you're eligible because of your discharge status for enrolling in VA, you're eligible for VA benefits. It doesn't matter how you identify yourself. All right. So I talked about minority stress earlier as an explanation for health disparities, or how these disparities get created. But it also offers some solutions. If stigma, stress, and discrimination in society and even personally contribute to the creation of health disparities, then reducing that stigma, stress, and discrimination should reduce some of those health disparities. So how do we go about doing that? A couple of different ways, actually multiple ways. We need to be doing all of these. It's not one solution that's going to work. We need to establish supportive policies for LGBT patients that we serve, as well as our employees, and improve systems of care so that we routinely assess sexual orientation identity and gender identity and veteran status if you're outside of the VA. We validate people's sexual identities and their gender identities. We assess for risk when appropriate, and also for resiliency. What makes people able to manage the stressors that they do experience and be as successful as they are? We can provide better training for staff and resources. We can create a more welcoming environment for LGBT patients that we serve, so we can overcome that expectation that they're going to be discriminated against. We can promote better patient-provider communication and offer culturally competent, affirming care. So let's talk about each of these a little bit. If you're looking for a place to start, though, and I don't know about UTMB if you all participate in the Healthcare Equality Index. Do you all do that? Okay, great. This is a great place to start because it's a self-assessment. It's voluntary. It's a self-assessment of how responsive healthcare organizations are to meeting the needs of the LGBT patients that they serve and their LGBT staff. And then based on scoring criteria, if you meet a high level of excellence, then you can be identified as a leader in LGBT care, and you can promote that status on websites and so on. And the VA encourages VA facilities to participate in the HEI, and many do. Let's look at policies for a moment. The VA has a couple of key non-discrimination policies. One for patients that includes a list of characteristics that we don't discriminate against. And in that list is sexual orientation, gender identity, and expression. There's also a non-discrimination policy for family members or caregivers of veterans who come to the VA, and it has the same list of characteristics. Also, it provides a very, very broad definition of family member. It's anyone that the veteran says is important in their life and their care is a family member. So nobody has to do a blood test, nobody has to show a marriage certificate. If the veteran says this is someone important in my life, they're a family. I mentioned the Transgender Healthcare Directive that came out in 2011. We reissued it in 2013, and we're in the process of getting it ready to be reissued. Health policies in the VA have about a 5-year lifetime, and although they may reach that expiration date, if there isn't another policy that rescinds it, that policy remains in effect. That leads to some confusion among people who see the expiration date and think that somehow the policy is going to end. It remains in effect unless the policy's been rescinded. But we want to be clear that this policy is ongoing, and so we're working to reissue this policy for 2018. At this time, we're not anticipating any changes in the policy. We are updating the frequently asked questions in the back because we've learned a lot from people in the field. We know what their concerns are, where they're having some confusion because of the questions that they ask. I've mentioned the LGB Healthcare Directive that we hope will be out this summer. We're working on the training for this directive so we can have the training come out at about the same time.
What's the difference between the LGBT healthcare versus advanced directives?
It's not an advanced directive, it's a health policy. It establishes what care the VA will provide for each of these populations. And for transgender veterans, the VA will provide gender counseling, hormone therapy, pre-surgical evaluations, support letters for those evaluations, and post-surgical care if it's medically necessary. If somebody has complications from a procedure performed outside of the VA will take care of folks after their surgery. And I think I mentioned that for the LGB directive, the important points are that healthcare providers will be asked to assess sexual orientation identity and do a brief history of sexual health and record that in the chart. So does UTMB have non-discrimination policies that include sexual orientation and gender identity and expression? Do they? And does that also cover staff? So patients and staff are both covered under the non-discrimination policies. Good. What about preferred name? This is a big, big deal among patients, and especially transgender patients, but it's a big deal for a lot of people who prefer to go by a name that's not their legal name.
We're doing that.
You're working on that?
We are doing it.
You are doing it. Great. Good. This is something that patients love because it feels more comfortable. They don't like to be called a name that's not their preferred name. We have a preferred name field that's in development right now. I don't know yet when it will be released, but it's in progress and it's pretty far along. You may have heard, if you watch the news about VA matters, that the VA secretary has said that VA will buy a new record system, a new health record package to replace our homegrown one, which has been very successful and was cutting edge when it was developed, but we're going to buy one off the shelf and one that's compatible with the Department of Defense. So even though preferred name hasn't been implemented yet, we feel pretty sure that all of the fixes that are in development are going to be carried over to a new system and will be implemented in a new system. And a lot of new systems off the shelf have preferred name. They also already have gender identity fields and sexual orientation identity fields. Now, it's important that healthcare providers, when talking about sexuality, about gender identity, put this in a healthcare context so patients understand why they're being asked this information. One of the objections that I often hear from healthcare providers when I go around doing talks like this is, I think this is a way of saying I don't discriminate, but they'll say, I treat all my patients the same. Well, if you're treating all your patients the same, you're not providing patient-centered care because your patients aren't all the same. They're all different. And you need to be aware of those differences and taking those into account to provide them the best health care that they need. That's good patient-centered care, not treating everybody the same. It's great if you don't discriminate, but you've got to be aware of their individual differences. It's also important to not start out asking about sensitive questions, but to build some rapport first and then ask those questions later. Also assure patients of confidentiality. I think the best approach, if it's possible, is to ask about sexual orientation identity and gender identity in initial intake forms and let people respond to those themselves, and the clinician can follow up with that information. Unfortunately, we don't do it that way at the VA, but I think that's the best approach, and I encourage agencies to include these demographic markers in the other demographic information that gets collected at intake. Part of the problem in healthcare providers talking about sexuality is that they're worried they're going to offend patients. And this was an interesting study that just came out, looking at over 1,500 LGBT and non-LGBT patients and over 400 medical providers. The medical providers, by far, believed patients are going to be offended if I ask them about sexual orientation. 80% said their patients are going to be offended. Minority, 11% of patients said this would be upsetting to them. It's not a patient worry, it's a provider worry. It's the providers who are uncomfortable. And why are they uncomfortable? Everybody's uncomfortable with sex. It's a societal kind of thing. But it also has to do with not having had training, not doing this routinely. So it's easier. So some ways that you can ask about this. If I were going to write the gender identity question responses, they might look more like this. So do you think of yourself as man, woman, a transgender man or trans man, a transgender woman or trans woman, gender queer? Is there something else with an open text field where you could track how people identify themselves? And then allowing the individual to not answer at this time, what I think would be a better set of responses. It's important to ask about sexual orientation identity, again, to be respectful of people and how they view themselves, and kind of their public persona, but also because health disparities are cued to how people identify themselves. So this will tell you what your next questions need to be based on their responses. So do you think of yourself as lesbian, gay, or homosexual? Understanding that homosexual is a pejorative term for many people who identify as gay. However, some older folks may prefer that term because that's a term that they grew up with. I've heard older veterans, for example, identify themselves as homosexual. I would find that offensive if it would be applied to me. Do you think of yourself as bisexual, straight, or heterosexual? Something else? Is there another term, again, with an open text field? Are you not sure at this time or don't want to say? That's perfectly fine. Notice that the first option is not heterosexual. Any idea why? Most people identify as heterosexual. Wouldn't that be the easiest thing to do? Then you can stop. You don't have to go any further in your assessment. Might save you a half second. Why not start with heterosexual? The literature shows that If you have heterosexual as the first response option, you get fewer differences in identity. People are less likely to identify themselves as a non-heterosexual category. So allow them to tell you who they are and communicate up front, you know, I expect to see non-heterosexual people in my clinical practice. And of course, you want to ask about sexual behavior if you're assessing sexual risk, so you want over some specific period of time. How many sexual partners have you had? Are your partners men, women, or both? Or are you not sexually active right now? It's important to ask about relationship status and also living situation. What is your living situation? I live alone with a spouse or partner, with roommates, with my parents or family members, or something else. Why is it important to ask about who the patient's living with? What's that?
To know about their support system.
Know about their support system, yeah. Another objection that I often get from healthcare providers is, and I love this one, why do I have to know about a patient's sexuality if I'm just treating their broken leg? Trivializes patient's sexuality and their living situation. Why would you need to know this if you're just treating a broken leg? Because that patient's going to go home and may need some help at home. Maybe they're okay with this broken leg, but maybe they need some help at home, and it's a good idea if you know who's at home who can help and the relationship this patient has with that person, how much information this person may have. And if you make the assumption that this person's in a heterosexual relationship and say, I hope your wife can take care of you when you get home, this is what she's going to need to do, and you've got a patient who's gay, you've communicated to that patient that you don't expect to see gay people in your practice. You've made an assumption about the patient, and a wrong assumption, and probably offended the patient who will never come back to see you. I wouldn't. And if you're not in the VA, it's also important to ask about veteran status. Again, because veterans are at higher risk of some mental and physical health conditions compared to non-veterans. It's unfortunate that a lot of other health organizations don't often ask about veteran status, if they've served in the military or not. And it is a risk factor, an important one. All right. We can do a better job of providing education and training to our healthcare providers to create a more welcoming and affirming atmosphere. Here are some trainings that we've developed in the VA. We've got 3 excellent programs on transgender care. One is an introduction to transgender healthcare issues that's great for non-clinicians and includes some embedded testimonials from transgender veterans who talk about their healthcare experiences in the VA and outside of the VA. We've got another program specific to mental health providers and how to make a diagnosis of gender dysphoria and how to do a hormone evaluation. And a third for prescribers. These also have the same embedded testimonials from transgender veterans. And some video demonstrations of positive, supportive clinical encounters and some that don't go well, as for contrast. They're very, very good. We've got 2 others more specific to LGB veteran healthcare, one on sexual health and one more on healthcare generally for LGB veterans. And I'm happy to say that these are all available outside of the VA on an internet platform called VHA Train. I think this presentation is going to be available to you on a PDF, so you'll have access to the links that are in here, and there are a lot of links. But this is a free service paid for by the Public Health Foundation that makes government-funded continuing education programs available to the public for free, and you can get continuing medical education for free by completing these training programs. Pretty cool. We also have 4 fact sheets that we developed about a year ago for gay and bisexual male veterans, for lesbian and bisexual female veterans, for trans men veterans and for trans women veterans. And we encourage, this is available on our SharePoint site, we encourage facilities to print these and put them in waiting areas so veterans can be educated about what they should be talking to their providers about. So they understand that these identity issues are relevant to their health care and can anticipate their providers talking to them about these issues, hopefully. They're also great educational tools for the providers who need to understand what they should be talking to their patients about. And I'm happy to say that these health fact sheets are available on the internet at our website address that's listed here. You can download them for free and print them off. We also have a really cool program that we launched a year ago, an LGBT point of contact program, which establishes a part-time collateral duty called an LGBT Veteran Care Coordinator at every facility. Some facilities have identified more than one person to play this role, which is great. And this LGBT Veteran Care Coordinator does an assessment of the kind of state of clinical services for LGBT veterans at the facility and looks for gaps and tries to then address those gaps and create the services needed. The Veteran Care Coordinator also trains staff across the hospital where needed, works with the hospital to create a more welcoming environment, and liaisons with LGBT community organizations. So so we can share resources, share information. VA can't provide everyone's needs all the time. It's great to work with community organizations that can be supportive. We provide a number of clinical services for LGBT veterans, support groups, mental health therapy, couples counseling, gender counseling, hormone therapy, evaluations for gender transitioning surgeries, carry letters for transgender folks when their legal name or their appearance doesn't quite match their ID, and also culturally, clinically appropriate medical care. And I've listed our two SharePoints here. These are internal to the VA, so you can't access those, but this is really, we've got a huge repository of information at both of these SharePoints. It's the definitive place to go in VA for LGBT resources in VA. We also have another training program, which is pretty cool. I think this is our 4th or 5th year of an interprofessional psychology postdoctoral fellowship in LGBT health. And there are 9 facilities that have these 1-year fellowships for psychologists. And I'm happy to say our first LGBT fellow in Houston was your own Colt Kielmeyer, sitting up here at the top of the room. And about half of these fellows, all of our training programs in VA are intended to not just provide great training, but to serve as a pipeline for highly skilled, qualified trainees to enter the VA and become VA staff. And about half of the LGBT fellows stay in the VA or in federal service. A couple of other important training programs that we've launched over the last couple of years. An intensive team training for transgender care. We got some special funding from VA Central Office for 3 years, launch this program to train interdisciplinary teams in transgender care. Through a 7-month program, the teams meet twice a month through video conferencing. They get a brief didactic from our expert team, 10 or 15 minutes of didactic on transgender care, and then the rest of the time is spent on case consultation, which is great. This is a model that's worked for other health conditions and training people in remote areas to be kind of mini specialists in an area, like HIV or women's health or spinal cord injury or diabetes. And to date, we've been doing this for 3 years. We're running out of the central office funding, but to date, and we wrap up our last cohort tomorrow, I believe, We'll have trained 75 teams through this program and nearly 600 healthcare providers. That's amazing, really amazing. But the even cooler thing is that we got some additional funding through a VA Office of Rural Health to tailor this program to meet the needs of rural VA healthcare providers, those who are working in small hospitals or in outpatient clinics in remote areas. They have fewer resources, fewer supports, and so we've developed a briefer version of this program that's less than half the length, and we've removed the requirement to develop a team because it may be impossible for some sites where there's only one psychologist or one primary care provider, and nobody else is interested in doing this. But we're going to launch this new abbreviated rural focus program in August. And we've got 3 years of funding to help support this. Another clinical support program that I think is very cool is a national e-consultation service on transgender care. So any privileged clinician can ask a question about their transgender patient through the patient's medical record, and this consult will be routed to one of 3 teams that will respond to it. And a team is required because often the questions are complex. There's more than one question. They almost always involve the whole team to respond to particular questions. This has been quite successful. We launched this, I think it was completely national in 2014. We've responded to over 750 consults that are connected to at least 600 unique veterans. And that program will continue as well for the next 3 years through the Office of Rural Health funding. Now, all of us can work to create a more affirming environment. We can provide affirming treatment to the patients that we see. This is not a special technique that you have to learn. It's really a framework for providing treatment that involves promoting a positive view of LGBT identities and relationships, and recognizing that LGBT people live in a society where their identities are stigmatized, where they may experience discrimination every single day. They may have experienced it on the way to your office, from the parking lot through the waiting area. And that we work as advocates for our LGBT patients who need help, who need people who are supporting them, advocating for them. They often fall into cracks where there are gaps in services. A great transgender affirming document, if you don't already know, is the World Professional Association for Transgender Health Standards of Care, 7th edition, and this is a link that will take you to that the standards of care that you can download for free. This is kind of the definitive resource document on the international consensus on standards of care for transgender folks. We can also work to create a more affirming, welcoming environment by being aware of the signs and symbols in the environment that let LGBT people know they're welcome here. We live in a heteronormative culture that privileges heterosexuality, that privileges being cisgender, one whose gender identity is consistent with your sex assigned at birth. Cisgender people, heterosexual people are welcome everywhere. Everywhere is their space. Everywhere is not welcoming space for LGBT people who may be harassed or stigmatized or even experience violence in that particular space. So it's important that they know they're welcome, and you can show that they're welcome by having posters like these in your healthcare environment. These are some that we've used in the VA. We Serve All Who Served and the Assessing Sexual Health poster. We make them available to facilities and encourage them to print them and post them in the environment. And it's really gratifying when I make visits to other facilities and I see these in the hallway, and it's just an ordinary kind of thing. I think, wow, we've done this. The one at the bottom here is one that we did with women's health for Pride a couple of years ago. And there are others that are available too. So in closing, I wanted to leave you with a few do's as a take-home message. Create a welcoming, supportive environment. And be aware that your LGBT patients may come in to see you with the expectation that they're not going to be treated well, that they'll even be discriminated against, and work to overcome that. Ways that you can work to overcome that: display your health agency's non-discrimination policy in visible areas where people can see it. Add your preferred pronouns to a signature block to communicate your gender identity, your preferred gender. Sensitizes people to this issue. Add LGBT-friendly signs to the environment, especially around bathrooms. We're in a state where many people are concerned about the bathrooms that folks use. I don't know why, I don't quite understand it. We're fortunate in the VA because the VA is covered by federal policy, and federal regulations trump state law. And so on VA campuses, our non-discrimination policies are supreme. And we've got a policy that says patients can use whatever restroom facilities match their gender identity. We're not going to be the bathroom police. Review your forms, your intake forms and paperwork for inclusivity. Ask patients about sexual orientation identity and gender identity routinely at intake is a great place to do it. If you can get these included on the intake forms where other demographic information is listed, I think that's ideal. Use patient's preferred name and pronoun when you're talking with them and in the documentation. And I always document as if patients are going to read my notes, because they do. I've had patients leave my office, go to medical records, ask for a copy of the note I just wrote, and then bring it to their next visit. They do that. It can save you a lot of embarrassment if you're aware of patients will read your notes. And protect your patient's confidentiality. Lastly, I wanted to direct you to some resources where you can get a lot more information. The Joint Commission has a field guide for LGBT issues that's really terrific. The Fenway Institute has a toolkit called Do Ask, Do Tell, which is very good and available for free. The Gay Lesbian Medical Association also has a wealth of resources available for free. The last link here is our internet address for the VA LGBT health program. And you can download a lot of the health fact sheets and some other information from that website. The Fenway Health Institute also has a lot of trainings for clinical providers that are available for free. So does the Centers for Disease Control. Already mentioned the WPATH standards of care. And here's a link to take you to information about changing ID, which is important and also complex because every state has different rules about how this can be done. Already mentioned the VHA Train platform, which is great to get free CME. And my colleague Jillian Shippard and I have just finished editing a new text on adult transgender care for Rutledge that'll be out in November. And Colt has a chapter in that book as well. I think that's my last slide. Yeah, with that. This is an email address where you can reach me later. If you don't get a chance to ask a question or talk to me, or if something comes up later, you can always reach me at this address. And I thank you very much for your time and attention. So I'm not sure what the schedule is next or how much time is available for questions. There's some time for questions? Okay. Any questions? Yes. Okay. So the question is, do other healthcare providers like physicians and nurses have to take some mandatory training and be certified in LGBT healthcare? No, they don't. We expect this of everyone. We don't provide a certification to say somebody is now competent, and people who don't have this training are not competent in LGBT care, because that, I think, sends a bad message. It's also very difficult to require training of VA employees. We have to do a lot of mandatory training anyway, and it's very, very costly to take people away from their clinical care or other roles to do mandatory training. And so for that reason, it's very difficult to get any new training required. I wish we could do that. I think it should be, but I don't think that we should offer a certification that people are now qualified or certified or trained to provide LGBT care. It should be everyone's role. Good question.
I have two questions. The first one, you mentioned earlier in your presentation a number of people that have been sexually assaulted. What's the doing to help this or to deter this occurring?
To keep it from occurring is not the VA's role, because this often happens when women are still in the service. That's the Department of Defense's role. And for a long time, they did very little about it. And we probably only know the tip of the iceberg, because there have been a few studies done, a few surveys done of service members paid for by the Department of Defense. And these are anonymous surveys, but there is stigma in reporting. And in the past, when women and men have reported being sexually assaulted, nothing happened. And often they got punished for reporting it. There has been kind of a sea change recently, because this is epidemic. It's epidemic in the service. And it's really unsettling to think that your coworker, your colleague, the person that you're trained to work with and support you in the foxhole, is the person who's attacked you and sexually assaulted you, and now you have to work with them every day. So there has been a change, and the military has been given much more focus on letting people know that they can and should report this, and to follow up in prosecuting people who have committed assaults. I don't think they've done enough yet. There needs to be more, and the rates continue to rise. It's really unfortunate. Even though, and I'll add this, the vast majority of military sexual assaults are on women. Women make up a small percentage of the veteran population. About 1% of men are sexually assaulted in the military. That's thousands, tens of thousands of men who've been sexually assaulted in the military. They are the majority by far. And yet, you hardly ever hear about that. What the VA is doing is routinely asking about military sexual trauma when patients enroll in care. When they come to their first primary care visit, they get asked this question. It's not the first question, but they'll eventually get asked about military sexual assaults, as well as other experiences of trauma. And the provider is supposed to check up and follow up later and ask that question again, because people may not feel comfortable revealing this in the first or second encounter. It may be the third or fourth or 10th encounter before they're willing to disclose this. And then we provide treatment around sexual assault and PTSD symptoms associated with sexual assault. So that's what the VA is working on doing to address military sexual trauma.
So that should be a question you should ask as well.
If they're a veteran, yeah. Interestingly enough, lesbian and bisexual women have, compared to heterosexual women veterans, higher rates of childhood sexual assault before they enter the service, higher rates of military sexual assault, and higher rates of post-military sexual assault compared to heterosexual female veterans.
Another question. You mentioned earlier as well about veterans being afraid of losing their benefits because How about in the past, the history, there is history of that happening to veterans who were dishonorably discharged because of sexual orientation? Is the VA doing something to reinstate them so that they can get their benefits back?
That's a complicated question. Eligibility is based in part on your discharge status, and it's the Department of Defense which establishes that discharge status on your discharge summary, your DD-214. The VA can't change that. The Department of Defense can amend it, and there's a process to go through to get that amended. And if you have a dishonorable discharge, you're not eligible for many VA benefits. If you have a general discharge, you are, but not a dishonorable discharge. And it's true that in the past, some gay veterans or somebody who was alleged to be gay was discharged with a dishonorable discharge and they couldn't get their VA benefits. We have, and more recently, since the repeal of Don't Ask, Don't Tell, tried to publicize the process that veterans have to go through with the Department of Defense to get their discharge summary amended so they can be eligible. It's possible to do it. It's time consuming. We can't do it in VA because it's not the paperwork. We didn't create that paperwork. They have to do that. Now, what has been encouraging just lately is, and this is the first time I know of that it's happened, there have been strict rules about what services veterans are eligible for based on their discharge summary. But just recently, the VA secretary said that those veterans who've had bad discharge summaries, like a dishonorable discharge because of conduct disorder, are eligible now for mental health benefits. Because veterans who are not engaged in VA are more likely to commit suicide. If they're enrolled in VA, they're less likely to commit suicide. They're engaged in care. Veterans who are not enrolled in VA, more likely to commit suicide. And this is a way of bringing them in and getting them connected with some mental health care. Other questions or comments? Yeah.
I was still in New York a couple of months ago about hiring some suicide notes, and I was appalled how successful suicide cases. You talk a little bit about that specifically, and then are they hired for LGBTQ or what consent?
The suicide rate is higher for LGBT veterans. Again, not all of those veterans who commit suicide are in VA, the majority are not. And so we have no connection with them. It is uncomfortably high. I forget what the number is, estimated number per day, but it's way too high. And it's partly because serving in the military changes you. It can change you in a lot of ways. Especially if you've been in combat and you've seen horrific things. I've heard horrific things from those veterans, and it affects me and bothers me. I can't imagine seeing or participating in some of those things. And then coming back to a civilian life where other people want to treat you as if nothing's really happened, you're the same person who left, you're not the same person who left, you're a very different kind of person. It's had different experiences and a different way of thinking and feeling. And you as a veteran have not had a chance to work through those issues and figure out what it means to you and find a way to cope and find those resources that you need. Get connected with the VA. When people are discharged from service, it's done over the course of a couple of days. They're encouraged to enroll in the VA, but most don't, because it takes too much time. I'm not going to sit down and fill out all this paperwork and do this now when I could be on the bus home, see my family. I think it should be required that they all enroll in VA so they get connected with services right away, but unfortunately that doesn't happen. There have been some interesting comparisons about like the prevalence of PTSD in veterans in previous conflicts like World War II versus Vietnam and later, more recent conflicts. And some of the speculation that rates were a little lower in previous conflicts was that it took longer for people to get back home. It took days or a few weeks to sail back from Europe during World War II once your service was over, get processed through and get home. And that provided an opportunity to transition, to think about what's happened, figure out what's going on, what you're going to do when you get home, kind of put this in some place, figure out a way to cope with it. Nowadays, you're back in your hometown within a few hours. There's hardly any transition. And I think that has a cost. Yeah. Any other comments or questions? All right. Well, thank you very much again. I appreciate being here. Talking with all of you.
As students, we're the next generation of healthcare practitioners and researchers and those of us who work here to provide care to everyone who comes to our door, including LGBT patients. And so we have a gift for you.
Thank you.
You're welcome.
Very much. If I open it now?
Yeah, thanks. Yeah. We hope you'll think of us fondly here at UTMB. As I said to you earlier, you mentioned that you come to Galveston. We hope that you never need our healthcare services, but in case you ever do, we're right here. So
thank you.
Thank you so very much.
Thank you very much.
Yeah.
Appreciate it.
UTMB Health, working together to work wonders.